Okay, so you've made it to part 2 of the antimicrobial stewardship competency. We're going to take a look at laboratory testing and interpretation. We're going to start off first with urine specimens. We see those pretty frequently and need to know how to interpret them to make sure that we are identifying infection versus colonization and making sure that we are getting the appropriate treatment on board. So when we look at the urinalysis, we see a lot of different factors. Some of the things that of note are whether or not there's blood in the urine. Glucose or ketones in the urine can be suggestive of diabetes. Leukocyte esterase or nitrates we're going to talk about in a second. Those are potentially indicative of a bacterial infection. If there's white blood cells in the urine, that also is a warning sign. And sometimes the specific gravity can be a little off. So nitrates are produced when bacteria in the urine reduce nitrates to nitrites. So not all bacterial species produce nitrates, but when you see it's positive, it's pretty suggestive of a bacterial infection. So those that do produce nitrates, examples are Pseudomonas species and Enterococci. It can take up to 4 hours to produce nitrates, so if for some reason it's negative, that doesn't necessarily mean that they're not there, it just might have meant that you caught the infection early. Leukocyte esterase is made by neutrophils in response to the presence of bacteria. So the presence in the urine indicates presence of white blood cells in the urine, which may or may not indicate an active infection. But if white blood cells are not present, the organism may be a contaminant. So leukocyte esterase is a pretty good determinant of whether or not a patient has a bacterial infection. If it's elevated, so a lot of times they will have different categories. Sometimes they might call it small, moderate, large. So for small, it could potentially still be contamination, but for moderate or large, you know that you likely have pretty good bacterial infection going on. If white blood cells are not present, the organism may be a contaminant, and if there's greater than 5 to 10 white blood cells, inflammation or infection may be present. So you always have to rule out inflammation as well. But when you look at nitrates, leukocyte esterase, white blood cell content, and then look at symptomatology of the patient, you can pretty much figure out whether or not they likely have a urinary tract infection. Don't assume that just because a urinalysis was done that they are suspecting a urinary tract infection. Sometimes it's a diagnosis of exclusion, the patient's having other symptoms, and sometimes it's done for other reasons. A lot of times nephrologists will do urinalysis testing to see if there's specific issues with the urine overall. Bacteria are commonly present in urine specimens, so it's really not something that indicates whether or not you have an infection, especially depending on how the specimen was collected and if there's fecal contamination. Another thing to note is you may not see white blood cells in the urine if you have a neutropenic patient. So neutropenic patients, general classification for them is an ANC, or an absolute neutrophil count of less than 1,500. So it's important to take a look at the patient as a whole. There's also the potential for vaginal contamination in a clean catch specimen. So that's why if you see bacteria again, you know, it may just be contamination, not an actual infection. Typically labs, when they see that a urinalysis is positive for nitrites, leukocyte esterases, or white blood cells, will have a reflex urine culture. So you'll be expecting to see results. If you don't start to see results and you've got a positive urinalysis within 24 hours, then you'll want to actually ask if a urine culture was done because it might be a lab error. So this is a nice summary table that talks again about the different aspects of the urinalysis and the accuracy of each aspect in predicting the likelihood of a urinary tract infection. So it talks about sensitivity versus specificity. So sensitivity is the ability of a test to correctly identify those patients who have the illness, or it's otherwise known as the true positive rate. Specificity is the ability of the test to correctly identify those without the illness, or true negative rate. So when we look at this, for bacteria, an indicator of infection can be any amount of bacteria. But we notice that this has a low sensitivity and a high specificity. So low sensitivity means that there can be false positives. High specificity means that when it's not there, you pretty much don't have a UTI. Leukocyte esterase, high sensitivity and low specificity. White blood cells, again, high sensitivity, low specificity. Nitrites, low sensitivity and high specificity. So it's low sensitivity simply because not all bacteria make nitrites. Red blood cells have low sensitivity but high specificity because hematuria is very common in infections. Epithelial cells, so high epithelial cells indicate contamination with skin flora. And then pH has a low specificity. There's many other causes of alkaline urine than just a urinary tract infection. So when we look at, so somebody has a positive urinalysis and a urine culture is done reflexively, we have to interpret the urine culture based on some patient-specific factors. So does the patient have a urinary catheter? The presence of a urinary catheter increases the risk of UTI. Whether it's a temporary catheter or more of a long-term catheter, it doesn't matter. Biofilms can form, which make eradicating pathogens very difficult and can serve as a reservoir for multi-drug resistant pathogens. So it's really important when you've got somebody who's got a long-term catheter to figure out, are they just colonized or are they actually infected? Because if you're treating just colonized organisms, you're actually going to select for more resistance. You're going to create more of a problem for your patient and increase their likelihood of having a multi-drug resistant infection in the future. Whether or not the patient is symptomatic. So if the patient's asymptomatic, we definitely want to consider colonization versus infection. Patients who are asymptomatic and have a chronic Foley do not require antibiotics. Patients who are asymptomatic and are pregnant do require treatment because you can have the bacteria ascend the urinogenital tract and cause an infection in the fetus when someone has a urinary tract infection, simply because of the close proximity of the urethra and the vagina. Signs and symptoms of infection include pain on urination, frequency or urgency, fever, leukocytosis, and elevated C-reactive protein. Aspirated specimens are less likely to contain contaminants than specimens from indwelling catheters or using the clean catch technique. So what's an aspirated specimen? That's where they take a needle and they put it into your bladder and they withdraw the urine directly. Because it's not going through the urinogenital tract, there's less likelihood for contamination, especially with fecal bacteria, and so these aspirated specimens are a lot cleaner. Clean catch, really requires a lot on technique, so and cleanliness, so there can still be contamination with that as well. And then there's also straight catheterization. So sometimes when you've got someone who's got urinary retention, or you have somebody who's altered and can't give you a quality urine specimen, you'll insert a catheter to try to get urine directly out of the bladder. Now it's going to depend, were they a chronic Foley patient and you're doing the straight cath because you want to change the Foley? Are you doing a straight cath because they're altered? Are you using appropriate technique? So even with the straight cath method, there's a lower likelihood of contamination, but it is still possible. So it's very important to know how the urine was collected in trying to rule out a contamination versus an infection. So when you're looking at urine cultures, it's very important to look at different factors to determine, is this a true positive or is this a contaminant? So what was the time to growth? The faster you have a positive urine culture, the more likely it is a true positive or a true infection. If it takes greater than 24 hours for the bug to grow, it's likely a contaminant unless the organism is a slow grower. We don't see a lot of slow growers in urine cultures. So very slow, greater than 24 hours to positive, likely contamination. How many bacteria are present in the specimen? We're going to go over this in a little more detail, but bacterial counts do have thresholds. If they're above the threshold, they're considered to potentially be a pathogen. If they're below the threshold, they're likely to be a contaminant. Is there more than one microorganism there? Polymicrobial interpretation is very difficult. There are some patients who are going to be colonized with multiple bugs, and the likelihood for multiple organisms to cause an infection is small, but it can still happen. Is the organism isolated a likely pathogen? So this is something where it's important to know what are your likely urinary pathogens. And if you get something else, to know, hey, this is likely a contaminant versus an active infective organism. And if the patient has a catheter, has it recently been changed? So you really don't want to get a urine specimen when you're suspecting a UTI out of a dirty Foley. A lot of times what they'll want to do is change the Foley out, then get the urine specimen, and then analyze it. If you're doing it through a dirty Foley, we talked about biofilms, we talked about reservoirs of infection with those different Foley catheters, so you definitely want to know whether or not the catheter was changed if the patient does have one. So for bacterial counts and determining whether or not something is positive, if somebody used the clean catch method, those positive cultures are typically greater than or equal to 100,000 colony-forming units per milliliter of a single organism, or greater than or equal to 100 colony-forming units per mil in patients with symptoms, and white blood cells greater than 5 to 10 in their urinalysis. If the sample was obtained via straight catheter or suprapubic aspiration, positive cultures are greater than or equal to 100 colony-forming units of a single organism. When we take a look at the number of urine culture isolates, it's going to be based on specimen collection. So if it was aspiration or via a clean catheter, if you've isolated one organism and it's less than 100 colony-forming units, it's probably a contaminant. If it's greater than or equal to 100, it's a significant isolate. If you've got two organisms isolated and it's less than 100 for each one, they're probable contaminants. If it's two organisms isolated and it's greater than 100 for each, it's potentially a significant isolate. Two organisms and greater than 100 for one but not the other, then it might be a significant isolate and a contaminant. If you have greater than three organisms and it's 100,000 for one of them, that's probably a significant isolate and contaminants. And if it's greater than or equal to three organisms isolated with greater than or equal to 100,000 for each, it's probable contaminants. You probably have somebody who's really colonized with several different bacteria. When you have a specimen collection that was a clean catch from an indwelling catheter, a nephrostomy tube, or other types of tubes or devices, you want to take a look again at the number of organisms isolated versus the amount of growth. So if you've isolated one organism and it's less than 100, it's probably a contaminant. One organism and greater than or equal to 100, it's probably a significant isolate. Two organisms greater than 100,000 for each, significant isolates. Two organisms and greater than 100,000 for just one, it's likely an isolate and a contaminant. Two organisms and less than 100,000 for each, they're both probably contaminants. And greater than or equal to three organisms with greater than or equal to 100,000 for one of them, it's probably a significant isolate and contaminants. And then greater than or equal to three organisms isolated with greater than or equal to 100,000 count for each, they're probably all contaminants. You probably have somebody who's really seriously contaminated or has a lot of colonization. So what are the likely urinary pathogens? In the last lecture, we talked about the antibiogram. So I encourage you to go back, take a look at the antibiogram, and look at our sensitivity and resistance data for each of these likely urinary pathogens. So we figure that a lot of urinary tract infections are caused by gram-negative rods. There's also a role for yeast, and then also for Staphylococcus species with catheterized patients. So what happens when we get a urinary culture back? So this is an example of a urinary culture report that was done at another institution that will remain nameless. So when we look at the culture, we see that there was greater than 1,000 to less than 10,000 colonies per milliliter of 2 gram-negative rods, and then greater than 1,000 and less than 10,000 of Corynebacterium species or Staphylococcus species, multiple strains. So basically what they had here was a lot of different verbiages to help assist physicians. But what they're trying to communicate here is these are really likely contaminants. Take a look at how the patient's doing. Take a look at where the culture was obtained from, how it was obtained. If it was from a basin where somebody was just collecting urine. Take a look at the cleanliness of the situation. In this situation, we've got a urinary culture that is positive for one organism, and it's a Klebsiella species, which is a gram-negative rod, and greater than 100,000 colony-forming units per milliliter. This looks like a robust, positive urinary culture. You'll notice that afterwards it has the sensitivity data. So if we take a look, it's got the sensitivity data and the minimum inhibitory concentration for each bug. So for ANSEF, for instance, we notice that it's resistant to ANSEF, and its minimum inhibitory concentration was greater than 16. That's typically micrograms per mil. Rocephin, it was sensitive. Cephalexin, not surprisingly, because it was resistant to cefazolin and their cousins, was resistant. Ciprofloxacin, it was sensitive. Levaquin, it was also sensitive. Nitrofurantoin, it was sensitive. And trimethoprim with sulfamethoxazole, it was also sensitive. So based on patient-specific characteristics and allergies and the sensitivity patterns of the site, we determined our different empiric therapies. Now that we have definitive culture information, we can choose the best antibiotic based on the patient and what the patient's situation is. So we're going to take into account again allergies, different types of drug interactions, or patient-specific disease states or factors in order to determine which antibiotics would be a good idea to start in this patient. So it is sensitive to Cipro. It's also sensitive to Levaquin. In those patients with dementia, we might not want to use this as much because we do know that quinolones can have a negative effect on CNS activity in elderly patients. We also know that QT prolongation is dose dependent. We don't need to use a high dose of these antibiotics in patients for urinary tract infection because the fluoroquinolones do isolate very well in the urine. But we do need to take a look at what is their overall risk and are they on any other QT prolonging medications if they have a history of an arrhythmia or they have some severe heart disease where they're already receiving antiarrhythmic therapy. Now, nitrofurantoin is a drug that can be very problematic in the elderly. So if you've got a patient who's got a creatinine clearance of less than 60, you really don't want to use nitrofurantoin in them. And why is that? It's because it does not concentrate well in patients with low renal function. Also in elderly patients, it's been known to be associated with peripheral neuropathy even with single doses. And it's not immediate development of peripheral neuropathy, but it can happen months down the road. And then there's trimethoprim with sulfamethoxazole. So we're going to want to take a look and see, are there any drug interactions? Does the patient have a sulfa allergy? So we're going to take all these different factors into account when we recommend definitive therapy. So now let's take a look at blood specimens. So there's several things we have to take into account when considering blood cultures. Where the culture was taken from, how long has the line been in, has the patient had recent surgery, penetrating trauma, or existing infections, and also, the way in which the culture was taken, and how many vials were positive. So we'll talk about that in a little bit. If somebody has a line, and you do a central line culture that's positive, and then you have negative peripheral cultures, that may actually be indicative of line colonization, and the line may require changing. So a lot of times when somebody has a pre-existing line or port when they come in, sometimes they'll access that in order to get the blood specimens. But it's important to get those other peripheral cultures as well so that we can detect colonization versus actual infection. Infection risk does increase the longer the line is in place, and a lot of these central lines have recommended durations, or even the peripheral lines have recommended durations upon which they should be changed. In general, when we're looking at bacteremia, adult patients are likely to have low quantities of bacteria in the blood, even when they suspect sepsis. So in general, bacteremia in adults is intermittent. And for this reason, multiple blood cultures, each containing large volumes of blood, are required to detect bacteremia. Because, you can have false negatives. Prior to initiation of antimicrobial therapy, at least 2 sets of blood cultures should be taken from separate venipuncture sites. The technique, the number of cultures, the volume of blood are more important factors for detection of bacteremia than timing of culture collection. So while it's very important to get it before antibiotics have already been started, what actually gives us the most information is when the cultures are done accurately. The optimal volume for each blood culture in adults is 20 milliliters, so if we get less than that, we have a higher risk for a false negative as well. Careful technique is critical to avoid contamination of the blood culture media by normal skin flora during the process of collection. So it's important because normal bacterial skin flora can also cause systemic disease, such as infective endocarditis, and in some circumstances, blood culture contamination can make it really difficult to distinguish between false positive results and a true infection. Measures to reduce contamination include effective disinfection of the venipuncture site and avoiding blood culture collection through existing intravenous lines. A blood culture set consists of one aerobic bottle and one anaerobic bottle. And so aerobic means with oxygen, anaerobic means without oxygen, because the bacteria require different conditions in order to ultimately grow and flourish. Positive single culture may not be interpretable, so you're doing two sets of cultures. If one of the two is positive, was it a sampling error? Is it a contaminant? How do you interpret that? If a possible contaminant is reported on a single culture, additional culture data is needed. You'll oftentimes see physicians write for serial blood cultures either to watch for the bacteremia to clear, or if there's a contaminant to see, do we have issues with sampling, or is this a real pathogen? The problem is if there's a contaminant, a lot of times in the interim before we get our final answers, unnecessary antibiotics and unnecessary testing are pursued. It adds risk to the patient, it adds increased costs, it increases the length of stay. So it's really important that these things get done right the first time. A single blood culture also lacks sensitivity and really precludes the ability to distinguish contaminants from true bacteremia with bacteria that are common contaminants. Really common contaminants are coagulase negative staphylococci and diphtheroids. Most clinically significant bacteremias are detected within 48 hours with the use of instrument-based continuous monitoring blood culture systems. Detection of fungemia may require 24 to 48 hours of additional incubation. Both common and fastidious pathogens may be detected within 5 days of incubation with modern automated blood culture detection systems. An extended incubation beyond this time frame is generally not necessary. Again, time to positivity. If it's taking a long time for the blood culture to become positive, it's more likely a contaminant than it is a real pathogen, unless you're looking at fastidious organisms. So fastidious pathogens generally have very specific growth requirements and can be slow growers when we try to culture them. Or pathogens that have very low numbers in our potential contaminants can take a long time to turn positive as well. There's generally two clinical patterns of bacteremia. They're known as intermittent and continuous. So intermittent bacteremia implies that the bacteria are present in the blood for periods of time, followed by non-bacteremic periods. This is the most common pattern of bacteremia overall. It can occur following manipulation of infected tissues, such as like a surgical abscess drainage, following instrumentation of contaminated mucosal services like dental procedures, cystoscopies, or sigmoidoscopies, or in the setting of bacterial infections such as pneumonia, arthritis, like septic arthritis, osteomyelitis, soft tissue infections, and meningitis. Continuous bacteremia usually reflects a persistent endovascular infection, such as endocarditis or endoarteritis, suppurative thrombophlebitis, an infected aneurysm, or infection of intravascular foreign bodies, such as a vascular graft. So it also occurs in the first 2 weeks of typhoid fever and brucellosis, although in these diseases relatively few bacteria per milliliter of blood are detected. There's two major categories of infection associated with bacteremia, so extravascular infection and intravascular infection. Extravascular infections originate outside the bloodstream, so like pneumonia or a UTI, and they enter the vascular supply via the lymphatic system. Intravascular infections are associated with a primary infectious process within the bloodstream. Examples include infective endocarditis, suppurative thrombophlebitis, vascular graft infections, and mycotic aneurysm infections, and then also endovascular catheter infections. When we take a look at important pathogens when it comes to bacteremia, we talk about Staph aureus, Streptococcus pneumoniae, Group A strep, Enterobacteriaceae, Haemophilus influenzae, Pseudomonas aeruginosa, and Candida species. Viridian streptococci and enterococci may reflect true pathogens or contaminants, so you have to look at them within the relative clinical picture. So again, when we look at positive blood cultures, we look at the time to culture growth. Does the patient have an obvious infection source? Is the patient exhibiting signs and symptoms of an infection? Is the organism highly pathogenic, or is it more likely to be a contaminant? Is follow-up monitoring occurring? And is the organism a skin contaminant? Because we talked about before, if you're not careful with cleaning the site when you do the venipuncture, you can have a skin contaminant start to grow out of the blood culture. If time to growth is greater than 24 hours, that may indicate the contaminant, unless the organism is fastidious. Organisms growing from one culture site significantly faster than the other may indicate that the line is the primary site of the infection. If the blood culture is a true positive, you're going to want to repeat cultures after 48 to 72 hours to monitor for eradication of the organism from the blood. Follow-up blood cultures within 1 to 2 days of initiating antimicrobial therapy should be obtained in patients with Staph aureus bacteremia and in the setting of known or suspected endocarditis. Repeat blood cultures should also be obtained in the setting of fever, leukocytosis, or other signs of ongoing active infection more than 72 hours following the initiation of antimicrobial therapy. In those cases, we have to ask ourselves, do we have the right antibiotics? Did we actually isolate the pathogen? Are we using the wrong empiric therapy? In addition, repeat blood cultures are also useful in the following clinical circumstances. So a known or suspected site of infection with limited antimicrobial penetration, something like an abscess or a joint space infection. Something where the presumed source of infection is in the abdomen or the central nervous system, where there's a presence of a prosthetic vascular graft, an intravascular line, or cardiac pacemaker, when there's presence of pathogens that are known or suspected to be multiply resistant to standard antibacterial agents. We want to make sure that we're not selecting for some resistance. And if there's an unknown source for the original bacteremia, so you have sepsis or bacteremia of unknown origin. So how do we interpret blood cultures? So we've got false positives and false negatives. So false positives are typically due to multiple positive sites. Is less likely that an isolate is a contaminant if you have multiple positive sites. If 1 out of 2 is positive, you may actually have a false positive. But you also have to take a look and see what organism is actually isolated. So if it's skin flora, like coagulase negative staph, Staphylococcus epidermidis, or Corynebacterium, you're going to probably suspect contamination. So when you do blood cultures, the contamination rate is up to 6%. So you really have to look at your institution and what your likely contamination rate is as well. False negatives may happen due to improper sample collection. So either you didn't collect them before the antibiotics were started, you didn't collect enough blood. Those things can definitely majorly impact your ability to identify the pathogen. Improper sample storage, so they must be grown at a certain temperature. And so that can impact it if there's a delay in getting it to the lab. And then collection timing. So we just talked about, again, improper sample collection. Did you collect it after antibiotics were already started? Other things that you have to ask yourselves as well when you're trying to identify whether or not a culture is positive or not is, do we think that there might be a slow-growing organism involved? So something like a fungus or mycobacteria or fastidious organisms. Is the patient exhibiting signs or symptoms of infection still? Is the patient immunocompromised? When patients are immunocompromised, the list of likely pathogens increases greatly. If the patient is symptomatic, we want to make sure that we're reculturing to make sure that we're not selecting for the resistant bugs and allowing them to flourish and actually make the infection worse. And then we also want to rule out non-infectious causes of symptoms. So if you've got somebody and they're still feverish and they still have leukocytosis, we want to take a look at non-drug related causes. So some of the most, I'm sorry, not non-drug related causes, non-infectious causes. So some of the most common non-infectious causes that can actually mimic lab results that look like an infection are pulmonary embolism, that can look like kind of like pneumonia, steroids, so when we use corticosteroids you can see leukocytosis, and then also drug fever. So there's a lot of different drugs out there that can cause drug fever. The penicillins are actually pretty notorious for causing drug fever. They're one of the most common types of drugs that can cause drug fever. So you definitely want to make sure you're ruling these things out if the patient is not getting any better. Okay, now we're going to take a look at CSF specimens. So cerebrospinal fluid is obtained through a lumbar puncture. It can also be obtained through a drain or a shunt. And then you want to note whether or not collection was done before or after antibiotics were initiated. So lumbar puncture is a really standard method. Headache is the most common adverse drug reaction. Some patients might need to have a blood patch, so it really throws off the cerebrospinal fluid volume in some patients when you do remove some. A blood patch is basically where you take the patient's own blood and you insert it back into the epidural space. Typically they use about 20 mLs. Patient may have a shunt infection. We don't typically see those types of patients here, but if they have an open shunt because they've had some high intracranial pressures, the shunts can get infected. Shunt infections require, or they might require actually, replacement or intraventricular antimicrobial therapy. Most other infections are treated with systemic therapy only, and it's going to be dependent on the pathogen. Because some antibiotics just don't penetrate the blood-brain barrier very well. So in order to get high enough concentrations, sometimes you have to introduce them directly into the intraventricular space. If a specimen was collected after the antibiotic was started, gram stains and cultures are less likely to be positive. And blood cultures should also be drawn before antibiotics are initiated for a suspected CSF infection. A lumbar puncture might be delayed or not appropriate, especially if there's if the ICP is elevated and there's a risk for brain herniation. So sometimes you have to kind of start antibiotics blind before you can even get that lumbar puncture. It's going to depend on the risk versus benefit of doing an LP at that time. So how do we analyze cerebrospinal fluid? So one of the ways is to do a gram stain analysis. So it's pretty old school, and then they take a look at morphology of the organisms. So we've got 4 different common meningitis organisms. So we've got gram-positive diplococci, which is, basically 2 cocci that look like they're stuck together, and that's indicative of strep pneumoniae. There's gram-negative diplococci, which is indicative of Neisseria meningitidis. Gram-negative coccobacilli, which is indicative of Haemophilus influenzae. And then gram-positive rods, and when they look like this, they are indicative of Listeria monocytogenes. So gram stain is one tool that we use. Other tools that we can use include polymerase chain reaction. And so that's where you try to actually amplify the DNA or the RNA from the organism that's causing it, because meningitis can be due to viruses or bacteria or fungus. And so you want to be able to identify which organism it comes from. So there's PCR tests out there for herpes and for varicella zoster, and then some other pathogens as well. So when you take a look at cerebrospinal fluid analysis, they'll do a chemistry of it, and they'll look at the appearance. So what does a normal cerebrospinal fluid look like? It's typically clear and colorless. The white blood cells are less than 8 per microliter. The glucose is pretty low, so it's 40 to 75 milligrams per deciliter, or greater than 60% of the serum glucose. Total protein is 15 to 45 milligrams per deciliter, and red blood cells are typically not found. You will find red blood cells if it was a traumatic tap. So if the lumbar puncture was traumatic, you will likely find red blood cells in there. If you think it's viral, the appearance is it's still going to be clear. White blood cells are going to be less than 250 per microliter, and they're going to be mostly lymphocytes. The glucose is going to be greater than 50% of the serum glucose, or greater than 45 milligrams per deciliter. And that may be actually lower than that in HSV infection. Total protein is usually less than 200 milligrams per deciliter. And again, no red blood cells. Bacterial meningitis, which has a lot of morbidity and mortality associated with it. The appearance is going to be clear, cloudy, or purulent. White blood cells are high, greater than 100,000 per microliter, and it's going to be mostly neutrophils. You're going to see a significant left shift. Glucose is low, so it's less than 40% of the serum glucose or less than 45 milligrams per deciliter. Total protein is usually high, greater than 250 milligrams per deciliter, and again, no red blood cells. Fungal meningitis also has extremely high mortality. The appearance is going to be clear or cloudy. White blood cells are going to be 10 to 500 per microliter. Glucose is going to be less than 40% of the serum glucose. Protein is going to be greater than 50, and red blood cells are not normally found. Some of these normal values do vary with age. These are the adult values. If you're looking for neonatal or pediatric CSF analysis, you're going to have to go to other tables. There's also just some things that you can look at with the different analysis of the cerebral spinal fluid to rule out different causes of meningitis. And so if you've got protein that's greater than 220 milligrams per deciliter, there's actually less than a 1% chance that the infection is viral. When we look at meningitis pathogens, it's definitely age-related. So if the patient's less than 1 month old, so we see those patients in special care nursery, pathogens that are most likely to be there are strep pneumo or Listeria monocytogenes. Gram-negative pathogens be E. coli or Klebsiella. So you definitely have to look at the age of your patient and then correlate that to the CSF results and also correlate that to the gram stain that happens to figure out, okay, does this all make sense? Does the picture all make sense? Now we're going to take a look at wounds, and wounds can be very tricky to interpret. So we're going to try to tease out a few things to help you guys figure out colonized versus actually infected. When you're looking at a gram stain or a smear for a wound culture, you're going to want to look at multiple different things. And so right now, not all these things are being reported by microbiology, but Venga and I are going to pursue seeing if some of these things can start to be reported, because it really helps with our interpretation of whether or not the wound culture is positive or colonized versus contaminated versus an actual pathogen. So whether or not there's presence of epithelial cells. So that indicates that it probably didn't come from the wound, it probably came from the surrounding skin. So again, if something's positive, you might rule that a contaminant. Whether or not there's presence of polymorphonuclear cells. So polymorphonuclear cells are present when there's inflammation and when there's infection. So if you've got large numbers of polymorphonuclear cells, it's a pretty good idea that something's going on. And then how many organisms are present? So are they doing a count with the wound smear? If there's a lot of organisms present, so a high count, not necessarily all different types of organisms, but one organism that's got a very high count, it's likely an infection if contamination has been ruled out. If there's a moderate number of organisms present, it's possible infection or early infection. And if there's few organisms present, it's likely colonization unless it's a very, very early infection. Some of the symptoms of wound infection that you're going to want to look for in the ID note are going to be slow healing, thick exudates, pus, pain, swelling, and whether or not it's warm to the touch. So when we take a look at the wound culture interpretation, we want to see what type of culture it is, what type of specimen it is, was the culture done before or after antibiotics were initiated, how long has the wound been around, and is there a gram smear? So if there's a fluid aspiration, a sterile tissue collection, those are the best samples to actually get. They are less likely to have contamination. A swab is definitely more likely to have contamination. A swab is done and it's very superficial sampling. You're likely to get skin flora contamination, and so it's just not as helpful. Culture growth is less likely if it's done after antibiotics. That makes sense for any infection. and a gram smear in that case may actually be more helpful. If you have a wound that has existed for weeks, it's more likely to have gram-positive organisms. And if you have a wound that's been around for months, it's really more likely to be polymicrobial with mixed aerobic and anaerobic organisms. So when you have a wound culture, how do you determine whether it's contaminated, colonized, or infected? And what's the difference? So when it's contaminated, there's organisms present, but they're not replicating. They're just kind of hanging out because they live off of another surface. For colonization, organisms are present and replicating, but are not causing harm. They're not actively infected and don't need to be treated. And this is typically normal skin flora. So if you see the culture come back for Staph epidermidis, Cyanobacteria species, or Candida species, you have to ask yourself, is this just colonization that doesn't need to be treated? When you have an infection, there's organisms present and they're replicating and they're causing harm. One thing to note about contamination is all chronic wounds are contaminated. So you really have to be able to try to pick out which is the likely pathogen versus what's. So like I said before, when you get a positive wound culture, old chronic wounds are likely to have multiple pathogens and contaminants. So how do you treat them? It's important to be able to distinguish between what the pathogens are and the contaminants and look at the overall clinical status of the patient. Read the ID physician's notes to determine whether or not they're showing signs and symptoms of infections. Once you've identified what the likely pathogen is and which ones are the likely contaminants, based on the organisms that we've talked about previously, you're going to want to de-escalate antimicrobial therapy to just cover those that are likely to be pathogens and not those that are likely to be contaminants. By knowing the type of wound and knowing some of the different factors, so whether or not a patient's been treated with antibiotics before, it can help you with selection of antibiotic therapy. So you'll want to look at the IDSA's skin and soft tissue guidelines to make sure that you're using the appropriate antibiotics for these different common wound pathogens. So if you've got a new diabetic foot infection and no previous antibiotics, it's likely to be Staph aureus or beta hemolytic streptococci, but it's typically a monomicrobial infection and not polymicrobial. When you have a chronic diabetic foot infection, it's most often polymicrobial, especially if you've had previous antibiotics, and can include any one of the organisms listed. Cutaneous abscesses, furuncles, and carbuncles are complicated by the fact that they can be caused by skin flora or mucous membrane flora from a surrounding tissue. So say you have a abscess that's near the anus. You might be more concerned about fecal bacteria in that type of situation. Necrotizing fasciitis is a situation where it's very important to get antibiotics on board quickly and get them therapeutic quickly because this tends to be a very aggressive infection. It causes sloughing of the skin and soft tissue and can cause significant morbidity and mortality. Animal bites, cat and dog bites. Cat bites are oftentimes treated a little differently than dog bites. Cats' mouths are dirtier than dogs' mouths. Scientists claim that dogs' mouths are cleaner than humans' mouths, but we'll see about that. And can include any one of the bacteria that are listed here. Surgical site infection from a clean site, so not a gastrointestinal site and not from the female genitourinary tract. Is most likely to be a Staphylococci or a Streptococci genus. Surgical site infection from a dirty site, so dirty sites are those that already have bacteria in them. Typically gram-positive and negative organisms can be implicated, both facultative and anaerobic. So when you do have these types of infections, you're going to want to have anaerobic coverage along with gram-positive and negative. If a patient has neutropenia, and it's the initial infection, you're going to think coagulase negative staph, some strep, enterococci, Staph aureus, Cyanobacterium, Clostridium, and Bacillus. A patient with neutropenia who's had a subsequent infection, so not the initial infection, you're going to think multi-drug resistance. So you definitely want to make sure that they're on some big gun antibiotics and follow the guidelines with that. If you have a patient with an immunodeficiency, so a transplant patient or someone with lymphoma, you're going to be looking at some fastidious organisms. You're going to be looking at some slow growers You're going to have an increased risk of fungemia, and then also some viruses can be implicated as well. So when you have a negative culture, what do you do with that? So a negative wound culture does not necessarily mean you don't have an infection. So the question you have to ask there was there appropriate sampling? Certain organisms take longer to grow, especially if they're fastidious, or if they're just naturally slow growers like Mycobacterium. So you have to take a look at the overall clinical picture, rely on the infectious disease specialist to give you an accurate description of what the wound looks like, and whether or not the patient is febrile, whether it's warm to the touch, whether or not there's exudate or pus, and take all that into consideration. So let's take a look at a sample wound culture and try to interpret it. So in this case, there was a right foot drainage that was sent for culture in gram stain. And so when we look at the gram stain evaluation, we see that there was rare polymorphonuclear cells, rare epithelial cells, and few gram-positive cocci resembling strep. So rare polymorphonuclear cells, we know that polymorphonuclear cells are present and present in high quantities when patients have inflammation or infection going on. So the fact that we don't see these is not a very good sign. It doesn't really point to infection. Rare epithelial cells seen means that the sample was likely taken from the right spot. It did likely have did not have skin contamination. And then we see that there's few gram-positive cocci resembling strep. So that kind of leads us to believe that perhaps it's colonization. Because there's not really signs of an active infection going on, and we've got very few bacteria, it may just be colonization. So when they did the culture, they saw moderate growth. They saw beta hemolytic strep group A, and few and mixed normal skin flora. So it looks like there was a little bit of contamination and perhaps just some colonization. Sputum specimens can be tricky. So with sputum specimens, we want to take a look at gram stain and culture. And culture just does not work very well. About less than 10% of all sputum cultures are positive. Bronchial alveolar lavages are better for specimen detection, but obviously those are very invasive, and so they're not done as frequently. Of 33,000 patients that were diagnosed with CAP in a study that was done, only 7.6% had a pathogen detected. Expectorated sputum specimens are recommended for patients who are in the ICU, have antibiotic failure, cavitary lesions, active alcohol abuse, severe obstructive or structural lung disease, if the patient's immunocompromised, if there's a pleural effusion, if there's epidemic pneumonia, epidemiologic or clinical data suggesting a pathogen of clinical or epidemiologic interest, or if it's likely to be resistant to standard therapy. I mean, those are instances where you want to get the sputum, but again, we have to realize that the likeliness of actually isolating a pathogen is going to be very, very small. Because sputum cultures aren't too great, there's been other tests that have been created in order to try to identify different pathogens that can cause pneumonia. We would look at urine antigen assays. There's one for strep pneumoniae and Legionella pneumophila group 1. They're likely more sensitive and specific than a gram stain and a sputum culture. And the results are not altered by antibiotic therapy because they're looking for an antigen. They're not looking for active growth of bacteria. It may not be positive in patients who don't have bacteremia. So if you have a low bacterial load, the likelihood that this test is going to be positive is going to be pretty low. And you also cannot perform antimicrobial sensitivity testing because you haven't actually identified the bug. You have just taken a look to see if there's remnants of the bug available. Sensitivity and specificity for strep pneumo, when you're doing the urinary antigen assays, it's about 71% sensitive and 96% specific. 80% of Legionella pneumophila pathogens are group 1, so you're going to hit most of Legionella, but you are going to miss a few. So there could be some false negatives with Legionella as well. Procalcitonin is a test that we're looking to use more here at Ingalls. It's released in response to the presence of bacterial toxins. It's elevated in patients who have pneumonia or sepsis, and it must be done at diagnosis and then serially to monitor the trend. So we're taking a look at different protocols that we can use in order to help rule out patients who present with CHF versus pneumonia and get started on antibiotics till they can rule out pneumonia. People with chest x-rays that are inconclusive due to different structural lung disease. And you can also use this assay, especially with pneumonia patients, to de-escalate antimicrobial therapy. So what's the expectation of pharmacists when it comes to culture interpretation and looking at different tests to try to identify what the different pathogens are and whether or not a patient's on appropriate therapy? So what pharmacists need to be doing are reviewing, analyzing, and interpreting the results of tests and cultures. If you don't know how to interpret it, or if you want to find out if you're interpreting it correctly, you need to seek out help. You need to ask other folks who have a little more experience. You need to know what organisms are likely pathogens versus contaminants. You need to ensure that the patient is receiving the correct de-escalated or definitive therapy and recommend correct therapy if the patient's not receiving it. You need to know which antibiotics are the best to use to treat each type of infection at each site, knowing that different antibiotics have different penetration, and we talked about that in the last lecture. And we have to call the MD immediately if there's a drug-bug mismatch, because that means that the patient the entire time has been receiving incorrect antibiotic therapy. Video number 3 is going to be coming out soon. If you have any questions or concerns, please don't hesitate to talk to me. Thanks a lot.